Right now, I would like to introduce our two presenters. First, Dr. Gigi Chawla, who will be first up, I think, speaking, and then Dr. Michael Troy, both from Children's Hospital of Minneapolis. Thank you very much, both of you.
Thank you so much for having me here today. We're absolutely pleased to be able to talk to this audience about such an important topic and one that we're so passionate about. I'm Gigi Chawla. I'm a pediatrician at Children's. Is this a little too loud? It's sensitive. Okay. I'm a pediatrician at Children's and also a hospital doctor. I'm also the senior medical director of primary care for all of Children's outpatient pediatric clinics. I bring with me also my colleague, Dr. Mike Troy, who's the medical director for the behavioral health services at Children's and also associate medical director of the neuroscience program. He's been at Children's for 18 years. I've been there for 14, and together I think we have some experience in talking about early childhood development as well. He's a published author in this field. So we're here to talk a little bit today about early childhood development, specifically in the first 3 years, and what a critical juncture it is for our patients. We'd love to share with you some of the scientific basis from it, some of the medical issues that our patients are facing, and overall our clinical perspective on this topic. As far as our presentation today, at Children's, we'll talk about who we see, the challenges that we as an organization faced, the challenges that our kids, our population face, and our role in trying to assist in helping them. We'll also outline a couple of case-specific studies, my own personal patients, that we can chat a little bit about, and hopefully you'll see, especially with Dr. Troy's input, how the science really shows what changes in trajectory for developmental outcomes can make. Long before, kids are in school or even pre-K. We'll also end with a discussion, I hope, as well as some of your questions on the importance of community in really recognizing this really important topic and helping find solutions. Oh, yes. Nice. There we go. Sorry. So first off is who we are. Children's, as many of you know, is a place that takes care of sick patients, and we help them get well. I think we're known really for the great work that we do at that critical moment in patients' lives, but we actually do a lot more than that. As clinics, we take care of children who are also well, and we also have a critical piece in the developmental continuum for patients, really identifying where they are developmentally and bringing to light any plans for remediation, just as all of you are. As a commitment to early childhood development, Children's has really spoken with more than 30 community organizations. We've developed a position paper that Grant alluded to, and copies are available for you about the significance of this birth to 3 time period. And we'll definitely have our website available for all of you at the end. We have, as you might be more aware of, we have these 2 large metro hospitals, but in addition we have 14 outpatient pediatric clinics that span the metro area. And really this is from Rogers down to Shakopee, from Hugo down to Burnsville, and all the areas in between. And if you think of the depth and the breadth of that population, it really spans all that really the state of Minnesota represents, a wide socioeconomic background, a wide cultural background. So these are clinics that have well baby checkups from birth all the way through young adulthood. And they treat illness, but also function in trying to ensure that children's developmental needs are being recognized and met. This is where we do most of our developmental assessments for our patients. As an organization, we're a pretty busy place for kids. We have a lot of clinic patients and see, close to 400,000 patients annually. 60% of our patients are under 5, but 40% are under age 3. And so we really have a critical moment in each and every encounter to be recognizing where kids are developmentally. For these clinic visits, based on our socioeconomic background for this population, we translate into 62 different languages. And when we look at these patients, the breadth of our patients are that, more than 70,000 of them, 70,000 visits are interpreted visits. So it really is a challenge to think about how do you recognize the developmental needs across some of that as well. Our population is also challenging and vibrant and lovely in that, we see patients who are challenged economically, patients who are challenged with housing, transportation, patients who really are there only for acute visits and they actually don't want primary care, patients who really prefer to use the internet for access and just need us only on those critical times in their lives. And so I think it's a very challenging population and one that I know that you are also all well aware of. Overall, despite all of that varied background and all the challenges that we see medically in that population as well, as we serve a vast array of really complex needs patients, we know that despite the socioeconomic differences, despite the medical differences, that basically all kids need the same things developmentally in order to make the same progress. And so it's really recognizing that as pediatricians, that's one of the things that we're trying to promote and really look at is looking past those differences to see those similarities. Our role is really in helping patients know where their child is developmentally, teach them what they should be looking for in their child's upcoming development, and guide them through the process if they need remediation in any of it. And this is ideally happening at those well child checkups. And some of the barriers I might have discussed a little bit earlier in interpretation with live interpreters or phone interpreters, but also in what families are asking at the time, really recognizing that some families really just want a quick visit and they don't want a developmental assessment. Other families really are not even getting into the pediatrics clinics for some of those developmental milestone checks. And I think, when we look at what proportion of patients even make it in for a well child visit, it's right around 50%. And so we do need help from the community really assisting us at even getting patients into clinic or in to see any of you in order to really start the process of being monitored from a developmental standpoint as well. That failure to really track development is a huge social burden that we all need to find a way to get through together. And getting that message out to families is just a critical piece. So generally, barriers aside, we know that we can get this work done, and partnering with you is really how we would hope to do this. We look at school teachers, truthfully, as our role models. School teachers have a vast experience at managing 24 to 35 patients in a room, all at different developmental stages. And still find a way to make a personal touch and find a way to meet the developmental needs of their students. And as clinicians, we try to do the same thing. We see those 24 patients each day as well. They're different 24 patients, and we have a finite amount of time with each one of them. But one of the things that's really a beautiful thing for us is that we get to see them over the continuum of their life as well. So beyond second grade, we get to see what changes can be made in years to come, where they are in 5th grade or 9th grade or young adults. And definitely thinking about where they are as young infants and watching that trajectory over time is a critical piece to what our vision as well. We do this by building trusting relationships with families and helping them to see what little modifications families can make or what resources they can reach out for can ultimately make big changes in their child's lives. And we use our medical expertise as well to really lend to some of the work that you all are doing. So today, I'd like to get started a little bit by discussing a couple of patients of mine. And I think these patients are kind of the yin and the yang. They show different sides of a coin. They show what goes well and what doesn't go well, where we all have room to make adjustments and modifications, and where sometimes we're surprised by how well things are going. So these stories, they really help lay out developmental concepts that Dr. Troy will help elucidate a little bit further in more detail and show us what the developmental science really speaks to for these patients. I think they'll illustrate some of the developmental trajectories that really can go forward to change kids' lives, and we'll look at that as well. So let me introduce to you first Donnie. Donnie I met in the newborn nursery. He was born to a 44-year-old Caucasian mom. And really, I think the things that were striking about Donnie for me is that there was really minimal prenatal care. Mom really did not have any true feeding plans. And I think not a lot of forethought into actually having a baby. She didn't have a social structure, not much of one to speak of, and really no support plan. So it's really more of a desperate situation for her. And when I met them in their patient room, they were already, mom and baby, not engaged. Donnie was across the room. Mom was in her own bed. At one time, Donnie's father came in and pretty quickly just left again. And so there was not a lot of parent engagement. And I think with each well-child checkup, there were lots of challenges along the way. He was an ill infant with kind of routine illnesses, colds and cough and wheezing, but I think in a social structure that didn't have any ability to support those illnesses. His development all along was pretty borderline. He was meeting some of those milestones, but there were a lot of parenting challenges along the way with unstable housing, economic challenges, no reliable transportation, frequent trips to the emergency room as their primary care setting, intermittent employment, and that lack of emotional support by Donnie's father. And right from the beginning, home care nursing was involved with weight checks. Home-based therapies were engaged in trying to help with ensuring that Donnie stayed on an appropriate developmental trajectory, and to assist in educating the family about what are appropriate developmental milestones along the way. And frequent home assessments, both by home care and a childhood specialist, as well as frequent assessments in clinic occurred. But amongst the challenges, amongst these parenting challenges, were really a lot of disconnect in expectations for this child's development by the parents. And there was a lot of blame and disappointment. They would blame little Donnie for being ill, And at one point, at 6 months, they wanted him to be eating what the family was eating for dinner. They pushed to not have him carried anymore by 9 months of age. By 1 year, they wanted him to stop crying, and they would say to him, "You have to be a man." And by 18 months, he really needed to be potty trained. And they would ask questions about why isn't he doing these things? And they would be disappointed by those answers, not just my answers, but by the answers of the home care intervention personnel as well. So I think despite multiple recommendations for Donnie and his family, there were a lot of barriers to Donnie's family really being able to follow through with some of those developmental plans to keep him on track and to keep the family on track. So because of all of these things, I think that Donnie really experienced what we would all call toxic stress. And at this point, I'd like to show just a quick video of what some of the Harvard experts in developmental research talk about with toxic stress.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious, lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
So given what you've just heard about toxic stress, it isn't hard to imagine for all of you where my patient Donnie might be years later. He is now, I think, about 8 years old and is completely dysregulated. He really has no adherence to rules or structure. In clinic visits, for example, we've called at least 3 code pinks, which is our in-house terminology for a patient that has eloped and left the exam room and a parent or an adult cannot find him. And you can imagine in a children's hospital, that is a really big deal. I've also received many calls from the school system at why, my goodness, how challenging it is for all of them. He's been suspended a number of times. And I frequently get calls about, isn't there just a medicine that you can put him on that will solve our problems? And I wish it was as easy as just offering a medication for a child who has had such toxic stress and a different trajectory than we would like for his development. We have made many therapy referrals along the way for my patient Donnie, and it just has not been something that the family can prioritize in their other life stressors with lack of transportation, financial stressors and housing stressors. Obviously, we never give up on Donnie, and we expect every day to make a difference in his life, just as all of you would. And so we keep trying, and it's never too late, but it would have been so much easier to handle this or to really manage this at the front end of his life rather than already in his middle years. And so despite this being an extreme case, I think it's one to really illustrate all of what different developmental trajectories have to offer. And I think I'll ask my colleague and friend, Dr. Troy, to discuss why this is also critical.
Thank you, Gigi, and thank you very much for this opportunity. It occurs to me, I kept looking over at the grapes, and I grew up the middle of 7 kids, and so I'm really not used to people paying this much attention to me at one time. So if you'd like to get up and get some coffee and a brownie and grapes and stuff, seriously, it'll just make me feel more at home. So please go ahead and do that. It is wonderful to be here, and I'm grateful for the opportunity to think together and talk together, and to have some time to do it. Dr. Chawla and I, work every day in a very hectic environment, and to be able to sort of stop and breathe a little bit and talk and think together is a treat for us. So I'm going to march through some slides here, but we are going to have plenty of time for discussion and questions at the end. Just before coming up here, or before the program began, Grant and I were talking, and just talking about, I was asking about the composition of the likely audience and about some of his efforts. And I have no doubt that many of you know a great deal about the things that we're concerned about and that we're speaking about as well. But sometimes the trick is how to explain things with a logic that the other person understands. So if there's anything that Dr. Chawla and I say here, even if you already know it, but maybe hearing it, in a way you might have an idea or two, steal liberally. Take anything that we have to say or anything that we've published and use it, because that's really the point. So I want to begin by taking a step back from the specific and to the general. And I want to talk about development, something that we all understand, but I want to frame up our thinking for the rest of our time here, so that we are all thinking like developmental psychologists in a sense. So I'm going to take a little bit of time with this slide. I like this slide because it allows me to talk about a number of different aspects of development. When I am speaking to the med students at the hospital, and they're brand new in the environment, and they don't necessarily know a lot about development, I tell them if there's one idea, just one developmental concept to hold in your head and to be aware of as you move through your day, would be the idea of qualitative change from infancy through young adulthood. That's what's really miraculous and wonderful and amazing and fun about human development. The difference between a 3-year-old and a 6-year-old is fundamentally different than the difference between a 23-year-old and a 26-year-old. We know this intuitively, right? These are two different kinds of ages with different capabilities. The qualitative change that occurs between 3 and 6 is profound, and it reflects changes in brain development, and it reflects evolutionary processes that have developed over tens of thousands of years. So you're seeing this miraculous thing every day, but they don't know it. So I like to point that out first. And a lot of what we talk about here is going to kind of anchor back into this idea of qualitative change, because qualitative change and transformation occurs in a certain way. And it's the same whether it's cell development or a physiologic feedback system. Developmental change is directional, it's cumulative, and it's coherent. What I mean by that is it goes in one direction, like time. we attach special importance to early development, in part because it is cumulative, because the quality with which we resolve tasks and issues of one age becomes the basis upon which we then negotiate the next set of tasks and issues. And then all of that becomes the foundation for the next. So if you just think about it as a probability statement, as it were, the smart thing to do, to a certain extent, is to front load the probabilities back here. Because all of that directionality, the accumulation of those things, creates this developmental trajectory. I say it's coherent because at any point in this, we might look at one point. So we might think about Donnie and think about how he's doing at 8 and have a lot to say about it. But the way he's doing at 8 is very much related to how he did at 5 and how he did at 15 months and how he did at birth and how his caretaking environment did. So by taking this little shift into the developmental science, I don't want to lose sight of Donnie, of Donnie's family, or the next case that Gigi will be talking about. What I do want to do is introduce some ideas that will help us to translate that science into policy and into care, into education, into good clinical care with kids. So it's directional, it's cumulative, it's meaningfully follows one from another. And in that way we create this developmental trajectory. Another analogy that I like is if we wanted to hit Mars with a rocket, I mean, like if we had a rocket, and thought that would be fun, we could do it, but just a little bit of error at launch, unattenuated, will result in our missing the planet. So that's sort of this idea here of just a little bit of change here, all things being equal, will multiply and multiply. Now, I don't mean to say that it's destiny. That's not the case. The trajectory can change. But I would suggest that it can only change under certain conditions. First of all, somebody needs to know that the trajectory is off course. Secondly, you have to have the means to affect the trajectory. So we have to know it's off course, and then we have to have the ability to fire a booster rocket, for example. And the third issue is that nothing's free. That's going to cost us some fuel. To do that. And so it is with human development. Yes, we can identify somebody off risk here, but look at the work we're going to have to do to get them onto a better and healthier trajectory. It's going to be harder, it's going to take longer, and it's going to be more expensive. We like to say that early is better, but late is never too late. So it always makes sense to pay attention to Donnie, to try to make his life better, to help his family and to help his mother. It's never too late. But at every juncture, it gets later. And so we want to do as much as we can, as early as we can. Excuse me. Down on the bottom here, I've just listed trajectory. Developmental salience is another idea that's a very important one. I'm sure many of you are people that would be described, that somebody else would describe as being good with kids, comfortable with kids. But if you stop and think about what does that mean? What makes somebody good with kids? What is it? What do they do? And I don't mean book knowledge, by any means. But if you see somebody that is comfortable with children, that's good with kids, it's because they understand what's meaningful to that child at that age. They know what a 3-year-old thinks is funny. They know what a 7-year-old might be worrying about. They know what a 15-year-old is thinking about in terms of his or her future and what concerns them. They understand that at 15, you can have your heart broken, but you don't have the perspective to know it's going to get broken again. You understand what's salient and meaningful at each age and target it. So in Donnie's case, for example, when his mother is upset about when will he be toilet trained or when will he eat certain foods, there are two things at work there. One is she's worried about Donnie. She does care about Donnie. She's focused on Donnie, and that's good. The problem is she doesn't understand what's developmentally salient at those ages and what to expect. So resolving the thing that she's concerned about is impossible. And so you get this cycle of frustration. I sometimes say that, if for some strange reason we had to head over to the closest elementary school and we needed to know for absolute certain who the fastest runner in 3rd grade was, do you know what the most efficient way for us to do that would be? I mean, what could we do? Yes, I know you're a sophisticated group because somebody just said ask them. And that's right. We don't have to have a race because they know who the fastest runner is, don't they? They know for sure. But I'm willing to bet that when you all came in here, that thought hadn't occurred to you. I mean, maybe some of you, I don't know, maybe Dr. Charlie, you're the kind of person that walks in a room and says, I could definitely beat everybody here in a race. But for most of us, it's just not salient. It's not meaningful. But other things are, depending on where we are in our life and our developmental level and what the tasks are, lifelong. So that's the idea of developmental salience. Whether it's designing an intervention program, whether it's knowing what resources a family needs, like Donnie's family, we need to match what's developmentally salient at the right time, and we need to be sure that that the family understands why that's the case. And sometimes we forget that part too. Sometimes we know why something's important, but we forget to develop that understanding, a shared understanding with the parents. That's the idea of developmental salience. We're focused today on 0 to 3, not because there's something magical that happens at the end of that period, but I think in particular because of some of the points that Dr. Chawla made about being in a pediatric hospital, and I would say in particular the work of our pediatricians who are there with families from the very beginning. So we care a lot about that. Now it's all connected, and the next stage matters, and the next stage matter, and the next stage matter. But let's just, since I have the luxury of a little bit of time, talk about what's developmentally salient at this point. In the first year of life, really the issue is physiological regulation. It's actually just, kind of getting used to the sensory world, experiencing it, and in that process of experiencing it, beginning to wire our brains and develop the kind of physiologic feedback systems that will help us to take on that regulation ourselves. But at first, of course, it's the caregiver that has to do that regulation. So the infant experiences the world as managed by the caregiving environment. So the quality of that first year of life really has to do with the competence, confidence, and ability of the caregiver to provide developmentally appropriate care. That's all there is in that first year of life. That is the universe. No baby is at 6 months is lying there thinking, well, these guys are pretty good. But those parents next door, man, they're awesome, There is no point of comparison. This is the entirety of the world. There is no other world. There is no other caretaking environment. So if that caretaking experience is characterized by consistent and competent care, then the infant begins to internalize a model of the world as being a responsive, caring, predictable place. Further, things are going to go wrong, right? They're going to get hungry. They're going to poke themselves in the eye accidentally. They're going to need their diaper changed. And so they're going to be distressed and indicate they're distressed. Then what happens? The issue isn't that they're distressed. The issue is, does the environment respond to that? And do they do it in a competent way? So now we have a loop that says, when things aren't going well, I signal. And a loving, caring person, who's not perfect, by the way, and shouldn't be, that's no good, but is consistent, responds. Now I begin to internalize a sense that by my agency, by something I do, the environment responds to me, and it does it in a way that's helpful. When I'm distressed, they soothe me, or at least try to soothe me. When I'm alert and awake, they engage me and share in that delightful energy. And when I'm drowsy, they recognize that and they help me settle to sleep. So it's controlled by that outside, but it's internalized by the infant. And we like to say that confidence in the caregiver becomes confidence in oneself. It transmits from the caregiver into our own working model of what to expect from the world. And as many of you know, I can tell, that's what we mean by the attachment relationship, which is a profound and important developmental construct. As kids get a little bit older, and from that secure base of the attachment relationship, they're able to go out and explore the world. They're able to do that because they have confidence in that secure base. And at first, the idea is that we'll control the environment. You don't give a 16-month-old a fork and say, there's the light socket, don't put the fork in the light socket. You know, that would just be silly. You just cover the light socket, and by the way, don't give them a fork. But a little bit later, naturally, kids will begin to do something, and the parent will say, honey, you know, they're going to go take all the books off the bookshelf. And a competent parent at that age will say, sweetie, don't take all the books off the bookshelf. Grab two, bring them over here, and I'll read to you. Now, in that moment, what's happened is the parent recognizes a couple things. You have the beginnings of self-control. And secondly, this is your work now, and I'm going to help you do it. The competent caregiver knows that. They feel it, and they help construct that for that toddler. So the internalizing of external controls becomes part of the work of toddlerhood, through toilet training, through managing temper tantrums, beginning to delay gratification. That's the work of that age group. Okay. This slide, which we have in our handout, kind of points to the fact that. Well, I like to think of it as something that's really distinctive and amazing about human development, which is the idea of the extent to, we are born extraordinarily as extraordinarily immature beings. There is no other mammal that's born as helpless as we are, and sometimes this is referred to as like the fourth trimester. And I see that, you know, I got carried away with how much time I had, and now I'm behind. But I can't help it. It's so cool. One way to think about this is from an evolutionary point of view. At the time when the selection pressures were in place, what was our comparative advantage or set of advantages over and against the rest of the environment? Well, one important thing was that we were smart and could adapt to our environment. And to do that, we need a big, complex brain. So it's sort of like, yes, definitely, let's go with the big brain as our thing. But if you get the head too big to have that big brain and you can't get through the birth canal, that is not a winning strategy. You know, you'll go extinct. So then you got to say, okay, plan B. Go ahead and birth them, and then we'll carry them around. And so a lot of that first year of life, both in terms of the instinct of the caregiver is deep in our brain, that bonding toward the infant, and then over the course of that first year, that dyadic system, that relationship between the infant and the caregiver that cements in place, is our evolutionary way to adapt, to have the most sophisticated brain possible and survive. So you have this tremendous growth, proliferation of neurons within the first year of life, and then a process of pruning, of making those connections more efficient, and losing the connections we don't need and keeping the ones that we do need. So the next slide is a little video, also from the Harvard Center for the Developing Child, that talks about this with cool illustrations. Oh. Yeah. Maybe it needs me to do this.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later.
So with that in mind, that process of neural proliferation and pruning, let's just take a look at this next slide here. I like this one for a couple of reasons. So this maps out this maps out synaptic formation. So when the primary proliferation is occurring in these different areas of the brain. So it's a little bit complicated, but think about the sequence first. Sensory pathways, then language, then higher cognitive functioning. So first thing that's prioritized in terms of that process of proliferation and pruning is our sensory processes, because that's how we experience the world. The next are the basic language processes, because that's how we begin to interact in more sophisticated ways in the social world. And I don't have time, but I always like talking about it's really cool to think about a newborn infant, or I'm sorry, a babbling infant at several months is emitting every phoneme for every language, not only currently present, but ever present. We don't hear it necessarily, because if it's a nice, subtle little guttural thing that is in German, I don't hear it, and I don't respond. But if the baby says da, I'm like, he said da, which is part of dad. I'm on that, like, and we reinforce that. So it's miraculous, isn't it? And then a little bit later are the higher cognitive functionings. We take all those tools that we've accumulated, now we blend in the higher cortical functioning to use them in complex ways to solve problems, to have sophisticated social relationships, and so forth. So we have the sequence that you see, but also the slope. This happens very quickly, this happens gradually, this happens more slowly. We have also the volume of brain area reflected here. So it takes longer, but we have a lot of brain dedicated to complex, higher order cognitive functioning. And then the final point I want to make from this slide is even though the rate's different, the peaks come at different points, they all start back here. They're all a continuous line back to before birth. And then birth, and then after birth. So what we notice may be one of these domains or another, which is why we want to screen over time. So things that we noticed about Donnie perhaps at 3 in terms of self-control and how those issues were resolved. We didn't necessarily see it, but we could have predicted it would affect some aspects of these higher order self-regulatory skills. When to be silly, when to be controlled, how much is too much. So paying attention at different points in time doesn't mean just that domain, because they're all going to roll up together over time. At this point, it's just a cute rat, and it's a little rat pup, isn't it? And so I'm going to do an absurdly quick lecture on epigenetic phenomena. Yeah, no, it is that funny. So here's the long and the short of this. For a long time, we've understood that there's an interaction between our genes and the environment. That makes sense. and that we might have a set of genes that put us at risk for a disorder, but that disorder may or may not be expressed depending on the environment that we're in. The next level of science that's emerging, that's very exciting and very relevant to our conversations like this, is the epigenome. And we could think of genes as being the books in the library, and the epigenome as being which books are taken out of the library and read. So it's the switch on top of the gene. So what we're coming to understand now is, this has to do with rats, but you know, I'm making it fast. But what we understand now is that the environment acts not just on the gene, but on the switches that turn genes on and turn genes off. And so something that happens in the environment may activate a gene, and that gene will stay activated. And the real implication of that is that it can then be passed on. It can then be passed on as a switched on gene, or it can be passed on as a switched off gene. Does that make sense? So it's not just about that individual, but the next generation of individual. This is amazing science. The rats are up there because rats we're just very fancy mammals at the end of the day. So part of our brain's very much like a rat brain, and rats' life cycle's shorter. So you can see how some of this interaction between the gene and the environment occurs. And it turns out that to be a good rat mother is pretty simple. You need to lick your rat. And if you lick your rat, you've done an awesome job of being a rat mother. And if you don't, then you're a bad rat mother. And that's kind of it, really. And so you can get this nice, crisp visualization, in a sense, of specific genes and specific environmental factors. The analog, of course, is the caretaking environment that we as humans experience. So for somebody like Donnie, which genes that maybe he was vulnerable for got switched on because of what was happening in the caretaking environment, which will then be carried forward if unattenuated, if things don't change later on. So that's sort of my quick rat study. And this is simply to illustrate, this is another study that links maternal depression during pregnancy with specific genes that regulate stress reactivity in the infant. So certain specific genes that affect cortisol levels are switched on or off depending on whether the mother is depressed during pregnancy or not. And if the mother is depressed to a statistically significant level, certain stress regulator genes are activated and stay activated after birth. So it's a way of transmitting genetic change in that one generation because of the quality of life that the mother was having that'll now affect the quality of life that this infant is having. I think you all know that for all these risk factors, there are resiliency factors as well. And I do, since I've been talking a little bit about evolution, like to point out that we did not evolve to have a baby alone and in a high-rise apartment. We evolved to have a baby and then have that experience in the context of community. I mean, we're wired for that. We need it. And when it isn't there, then you have, from the starting gate, changed the probabilities of the outcome for that family and for that infant. And then I'll end with the dandelion and the orchid. And I'm curious, just by show of hands, how many people are familiar with this. It's been written up some in the popular literature. Okay. This is my other little epigenetic trick pony that I like to ride. For a long time, we've known that some kids are more vulnerable under conditions of stress, right? For genetic reasons, exposed to stress, they will develop a certain disorder or disease. And some kids do not. The question that wasn't asked for a long time is those kids that develop the disorder, what happens if what happens if we follow them under conditions of really healthy conditions? What if the environment is enriched? Do they just look average? And to make a long story short, it turns out that the children that were at greatest risk under conditions of stress, on many indicators, are the ones that perform most remarkably under enriched conditions. So that we've misinterpreted, to some extent, genetic risk for disorder, when in fact what we're often seeing is genetic predisposition to be sensitive to the environment that you're raised in. So for some kids, those are the orchid kids, they will do most poorly under conditions of stress, but they will do most wonderfully under enriched conditions. And for some kids that are referred to as the dandelion kids, they are resilient. They're not as affected by stress, but they also don't respond in as compelling a way in an enriched environment. I find this a very hopeful message in a sense. And those of you that work with kids, doesn't this make some sense to you intuitively? That some of the kids you've worried most about, you've thought, if they were just in this other environment, they'd have so much potential. That gut feeling that you had, I want to suggest was correct for many, many kids. And maybe it was true for Donnie, but we don't know. So I find it another compelling reason to pay attention early in development and to recognize that neuroplasticity is both a risk when things are not going well, but it's also very hopeful when things are going well. And now I'll turn it back to Dr. Chawla, with apologies.
Oops, I'm going to take mine. It's one of my favorite things in the world to sit and listen to Dr. Troy, and I really could do that all day. He really does talk like this all the time, and so it's not really just for all of you and your benefit. I tend to think of all of my patients as orchids and treat them all that way, and so we hope to make their environments to the point where each one turns into just this beautiful thing here. I did want to end on a slightly different note, and that's on my patient Maria. And Maria is just one of those orchids, and it's just one of those lessons that just makes all of our hearts sing a little bit, makes you keep going and makes you think, wow, I think I believe in the world again. And so Maria's mom was 14, and I met this family in the newborn nursery just a couple doors away from where I met Donnie and his mother. But it was a very different environment walking into that room. And so 14-year-old Maria's mother, she really already had a life's plan. She knew how she was going to raise her little one. She had a healthcare team all picked out. She knew how she was going to feed her baby. She had an entire room full of people who were dedicated in making this relationship work. 15-year-old dad sat at the bedside. 2 grandmothers were assisting, but not over-assisting, the 14-year-old mom in trying to breastfeed. And everyone, when I came into the room to talk about how beautiful their baby was, and to make sure that their questions were answered, all the older adults in the room looked at the 2 young parents to let them have their opportunity to understand that this is their time. And so it can be a really great thing. So this little one was born prematurely. She had a cardiac condition as well. She was still breastfed. We had home care involved and early childhood experts in the home. But really all of them said, you know what? They don't need us. They're doing it all on their own. And it wasn't for any types of steps along the way other than their own internal resilience. Maria had issues as well. She was in the ICU for cardiac concerns, but there was a village present around her, figuratively and literally at all times, ensuring that every step along the way Maria's needs were met. And it was a source of pride, and you could see it in each of our clinic visits, that everyone really kind of beamed on the inside and on the outside at how well Maria was doing. They took it personally. So where do we go from here? I think these cases and Dr. Troy's comments really help to paint the picture of how important early childhood development is for kids and is for our society. As Dr. Troy stressed, environment is critical, and we all play a critical role in making that puzzle fit together well. We have a lot of work to do in order to make this happen successfully for all of our patients all the time. But we'd love to take your comments or questions now and figuring out how we can do this better. Thank you.
Thank you both, Dr. Chawla and Dr. Troy. Thank you.
Mike, you want to come up?
Let's see, that's the URL if you want to connect to the study on your website, or if you just want to go yourself. Thank you both for standing here. I have some questions that I'd like to start with here, and you can decide who's going to answer. And I'm sorry, these might be kind of tough questions, but I think we need to ask them. This is a wonderful study, don't you think? Just really wonderful, very, very informative. But my question is, what is the vision of children's hospitals and clinics of Minnesota? What's the vision for this? What's the end result of this study? What are you hoping for? And then I have to ask the other one, how do we get there?
I'm going to miss Dr. Chawla. She's senior to me in the hierarchy of the hospital.
Oh my gosh. I wish we had all the answers, but we certainly don't. We play a pivotal piece. We know that. We have to developmentally screen our patients. We have to recognize and help families recognize when there's room for improvement. But we need to partner with all of you and find ways to really reach all of the kids all of the time, to get families recognizing, get into their homes, get kids on track developmentally, and so they're ready by the time they're in school. I don't think any one group, any one organization can do this alone. I think we need to find a way to blend all of the great work that all of you are doing, that we're trying to do as well, and make it into a really well-woven blanket that really helps all of our patients, all of our kids. I'm going to leave that to Mike to answer now.
Well, yeah, I mean, I guess it's a wonderful set of questions, a complimentary set of questions, and here are some things that we intend to do. Gigi and I and others are going to really look hard and ask hard questions of ourselves in terms of how are we screening systematically from birth through early childhood, right, Gigi?
Absolutely.
And then we recognize, I'll say this as a psychologist, that there's nothing physicians hate more than being forced to screen, identify something, and then have nowhere to send the child. And so the next set of work we have to do is to be more active in developing lanes of communication with the community, with people that are doing important work that we can partner with or have the kind of relationship that will make access easier back and forth, and to advocate ourselves for the right kinds of services once we've identified kids. That's the hard work we have next.
So I have some follow-up to that. Have you partnered with Lucinda Jensen in the State Department of Health and Human Services and the head of the Department of Health, whose name I'm yeah, and then also with Melvin Carter III, who's in charge of early childhood education in the Department of Education?
Yes, thank you. We've had some wonderful discussions with the Departments of Education, the Departments of Health and Human Services, and with Melvin specifically, who is so enthusiastic. I think everywhere along the way, everybody's excited about having a dialogue, and this is just a critical juncture where we need to start figuring out now where can we go from here? What can we do together? What does it look like? What's the roadmap? But yes, we've had some initial discussions.
And so then you talked about partnerships and things. Have you, in terms of nonprofits, working with people like Project for Pride in Living, Common Bond Communities, Minnesota Minority Education Partnerships? What what kind of nonprofit partners are you looking to or have come to you and said, we'd really like to have you be involved with us? Kelly, do you want to do this? This is Kelly Wolf, who also works at Children's Hospitals and Clinics in Minnesota.
Thank you. Yeah. My primary role is to work on the policy and advocacy pieces within the department. So to back up to the initial question, or the question prior about our conversations ongoing with the departments, one of the things I want to highlight, and one of the things that we're doing right now, is just really convening to try and find out how we can do a better job of this, how we can work together, because as Dr. Troy alluded to, we can't do this alone. So on September 22nd, we're actually bringing in Dr. Maxine Hayes, who is a former Washington State health official who's done some pretty incredible work on early childhood development in this area. And she's going to be coming in to have some conversations, one with our pediatricians and primary care professionals, to talk about how primary care professionals and pediatricians can do this, what that looks like, how we can do it better, and two, also to talk to our policymakers. And so we'll be convening a policymakers forum with the Department of Education, Department of Human Services, Department of Health, Office of Early Learning, to get all the stakeholders around the table so that we can start working on a plan going forward as a state to better address the population. The second question was, I have completely lost what the question was that brought me up here. Oh, the nonprofit organizations, thank you. Part of what, so we have, this process has really been a year-long process for us at Children's. We started this work about a little over 10 months ago now, and the very first thing that we did was start working on our outreach to community organizations, knowing that we had a unique voice as a healthcare provider, but that we were also very new to the conversation around early childhood development. And so we wanted to really do a thorough landscape of what was happening already in the community, the great work that had been done. And so part of what informed and influenced the paper that you have, and that's on our website, was really the result of over 30 conversations that we had with nonprofit organizations, department officials, agency staff, early childhood education experts. And so we did a very thorough kind of stakeholder analysis to make sure that whatever we decided to engage in and the message that we wanted to bring forward was really done well-informed and with a thoughtful purpose, and knowing where we could help plug in the gaps and add an additional voice. So we have definitely had those conversations. We look forward to having more. That certainly wasn't the end of them. As we learn more, I think there are more and more questions that need to be answered and more opportunities as well. So this is all part of a great and, I think, long learning process for us.
Great. Thanks, Kelly. One last question for me, and then I'll go to your questions. Unfortunately, we're all white folks here. I wish there were more people of color here today. I'm wondering if you've had a chance to present this wonderful presentation to communities of color that are all African American, all American Indian, all Latino, all new immigrants, to see how well this plays in those different communities.
Sure. The answer is no, but of course we'd love to. And actually, this is the second time Gigi and I have done this, so we appreciate your patience, and you're a very generous audience. But we hope it's the beginning of a larger dialogue. I assume that part of what informs the question, is what you are especially concerned about, which is the gap in achievement across different groups, and how do we account for that, and what's the answer to that. And so it's a conversation that we absolutely welcome. For starters, there's nothing that we talked about here that isn't relevant to anybody, any family, anywhere. That's number one. And number two, often when we're looking, and I want to be careful here because I don't for a moment want to sound like I think that any effort at any point in the developmental continuum isn't important. It's all important. But in particular, if you're looking at different parts of the community structurally, then it makes sense to keep looking earlier and earlier and earlier in terms of when to invest, in my opinion, and when to mitigate the differences that you see later on. It's like that developmental trajectory slide. So the further back you go, the closer you're getting to the point where we all need exactly the same thing. And so I welcome the conversation when we have the opportunity.
Great. I guess I have one last thing. Have you been in conversation with Senator Patricia Torres-Rey and Representative Carlos Mariani? Because I think this would be, don't you think, a wonderful presentation to those committees in the Senate and the House, ideally prior to the session, if you can possibly
hire you like an agent or something like that.
yeah, well, yeah, sure. No, but I'm sure you guys can do that. Kelly, you may want to speak to that.
Yes, and so I have to also point out that we have another good friend, Representative Mullery, in the back, and I was thinking as I saw him walk in that this would be a perfect opportunity to get in front of a legislative committee, because we have not had that opportunity yet. I know that Senator Torres-Rey was at the Mini Minds Coalition. We're members of the Mini Minds Coalition, and she was at the meeting last time. I have part of my role at Children's is I am their lobbyist, so I'm at the Capitol pretty much every day that they're in session. I know that they're all busy right now out on the campaign trails, but I absolutely agree that this is something that we would love the opportunity to get in front of some of the legislative committees and would welcome that. So I will wait for the invitation.
Most of the questions that you have offered are really about what resources are out there in the community that families can access in order to deal with some of these challenges that Donnie and his family have, because I doubt that Children's alone can provide all those resources. So I guess I would ask, so at the two hospitals in Minneapolis and St. Paul, when you're meeting with these families, are there social workers and others that kind of try to help these families understand what's out there and available, like early childhood family education, other things? And then I guess Kelly kind of hinted at this. There is a sense in which how involved is Children's going to get in making sure there are the resources out there in the community for these services, for the implications of your study?
As we make our commitments to really developmentally screen patients at all opportunities, it's really forced us to take a look at what is our next step, like Dr. Troy was saying. We've looked at models in which we utilize our social workers and our care navigators, our care managers within clinics and within the hospitals to really help us get patients and families on the resources that they need. It's a difficult task, and it's, as you know, community by community and county by county differences, but we do utilize our social workers to help us with that, as well as backline numbers that we all have and personal knowledge. But we'd really like to make it a more formal process and a network that we all interconnect and know where those resources are and make it more deliberate. I think the health department has really taken on championing this as a mission as well. Maybe Kelly, I'll let you speak to that as well. Yep.
Thanks. So what I can say is, with regards to the health department and the Department of Education, I know that they've been doing some great work, and somebody probably in the audience here knows far more about this than I do, but I know that there's been conversation about Minnesota following the Help Me Grow referral hotline, and so we've been in conversations with them about how we can be more of help or a resource in that work going forward. So those conversations are continuing, and we look forward to working with the health department and the Department of Education on seeing again how we can plug in and certainly be a resource. I know that referral piece is a huge one. Hennepin County and the Minneapolis Public Schools are doing some great work right now on the ABCD Close the Loop pilot project, really to help look at how are we getting information from clinics to schools and back and forth. There's a lot of duplication right now. And so I think one of the things that we are looking at, and we'll be looking at more, is how we can support and how we can help initiatives going forward that really allow for a more open line of communication from providers to school professionals to other social service organizations. We do have a bit of a disadvantage in Minnesota with some pretty strict privacy laws that make that sharing of data pretty difficult. So that is certainly something I think that's on our radar screen to help. I know there was a question that came up about what Children's is committed to in 2015. From a policy standpoint, it's a big legislative year, so there will be a lot of discussions around the budget. I don't anticipate any a budget deficit by any means, so I think we'll be in fairly good shape. We are members of the Mini Minds Coalition, which is supporting the 3- and 4-year-old scholarships. We are members of that and fully support the expansion of that and the full funding of that. In addition, I know that there is a lot of work from the Targeted Home Visiting Coalition looking at different home visiting type programs. That is certainly something that we would be willing to get behind and support. So I think at this point we are still investigating what those policy and funding solutions are going to be, but know that this good work cannot be done without those resources. And so we are committed to being part of the coalitions and part of that movement going forward.
Thanks, Beth. There's another question that has to do with teachers in the classroom, and one of the things that I've heard that frustrates a lot of teachers is they're expected to solve all these externalities for our society that are presented with them. So my question is, again, have you been invited or have you asked to speak with like Education Minnesota, the unions in Minneapolis and St. Paul, to help the teachers understand, based on this, what are the signs that they should be looking for these problems, and then helping them to know how they might access supports for the families, because it's just very frustrating for teachers that they're supposed to make up all these things that you've presented when really, Minnesota, we have one of the worst ratios of counselors and social workers to students in the United States of America. So it's very hard for them. Thanks.
First, let me just respond in terms of the incredibly challenging and difficult job that we know educators have. It's a final common pathway for lots of kids and lots of families. And I know I've heard Dr. Chawla talk in the past about how you look at, what they do in schools and how you look at your work and, similarities and differences. I think they share this phenomena of seeing lots and lots of kids for a variety of reasons. And for the most part, especially early in childhood, most kids are going to be at least involved at some point with a pediatrician, and then virtually all kids are going to be in schools. So I absolutely agree that we need to get services closer to both those junctures. So if I had, if I had my wish granted, it would be excellent and sufficient mental health resources built into the school system, which we're making progress on in Minnesota. And it would be the integration of mental health care, behavioral health care into primary care in a way that's effective and sustainable. And I have to say that some of the challenge of this reflects the bizarre way we have thought about healthcare economics in our country, and the way we have bifurcated mental health services and behavioral health services, and then those things over and against education. And it's as if we think these are different things, separated from one another. But we move through the world as single people, not as a psychological self, a learner self, and a physical self. And so it's crazy to make it so hard to cross over. We're very early in this process. I know Dr. Chawla is smart and articulate and graceful. So what you don't know is that she's helping to manage absolutely inpatient system that's bursting at the seams with hospitalized kids, and I couldn't do it. I would be agitated. I'm agitated. I don't have a reason, but you know, how do we clear the time to engage and do these things that you're talking about? And it does require commitment on children's part. And I would say that our efforts in terms of the paper, in terms of our being here, and the few other things that we've done thus far, and the work that Kelly's doing, is our saying, yep, you're right, we need to be part of that conversation in a more direct way. We want to be, not because we have all the answers, but because we're a children's hospital. We should be part of that conversation because we care about healthy kids and healthy families. So everything you've said is a great idea. Give us a little time, and Kelly, everything he said, then you go and tell our bosses, right? Okay.
Thanks, Michael. One last question, because it's close to 1:30. I'm going to ask if Dr. Troy and Dr. Chawla and Kelly, if you'd be available maybe till 1:45 for people who didn't get their specific questions addressed, so they can talk to you. Also, you've been very gracious. You haven't been getting up and going over to get things, but there are a lot of things there. I hope you'll take with you cookies and bars and fruit and things. Otherwise, I'm leaving them to the staff here at the synagogue. So please feel free to take those with you. Another question I have is, you know, Art Rolnick has been very effective in bringing to our attention the studies that have been done on the value of quality early childhood education, whether it's 1 to 17 or 1 to 13 dollars spent and value we get out of it. I'm just curious, are there any national studies that have been done on interventions in the 0 to 3 in terms of if we put X amount of dollars into this is how much we get out of it, or the other way, if we don't, this is how much it costs us?
My quick answer is that part of the genius of what Art Rolnick has done is that his voice is not the voice of a child education person. His voice is the voice of an economist. And I think that when we're able to get people outside of our disciplines to advocate for the things that we value, it's a more compelling case to make in general. So are there studies out there that link meaningfully what happens in 0 to 3 to outcomes? Many studies. Is there a sort of a landmark economic case that's been made with that kind of clarity? I don't think so. There are networks and there are researchers. There are, 0 to 3 has done a lot of fantastic work. But that somebody that's crystallized it that way and that effectively, maybe I see heads like, no, there is absolutely, and that'd be great. I'd like to know about it. I know networks of researchers. I don't know that kind of network, but it should be there.
I want to thank Children's Hospitals again for this wonderful study. Makes everybody aware of how incredibly important 0 to 3 is for the life of a child. I thought the presentation was excellent. Thank you again very much, and thank you all of you for being here.
Oh, okay.